Hello, everyone. Welcome to today's Medscape education program, which is entitled Improving the Timely Diagnosis of ALS Starts in Primary Care, Identifying Red Flag Symptoms. My name is Dr. Rick Bedlack. I'm the Stewart, Hughes, and Went Chair of ALS at Duke University in Durham, North Carolina, and I'm pleased to be joined by my colleague, Doreen Ho. Doreen, would you introduce yourself?
Thank you so much, Rick. It's my pleasure to be here. My name is Doreen Ho. I am a physician investigator at the Healy Center for ALS at Massachusetts General Hospital. I've been doing ALS for over 10 years, and I'm very excited to be here with you today, Rick.
Fantastic. Well, I'm excited too. We're glad to bring you this program. And over the next 30 minutes or so, we're going to be discussing how to identify and diagnose ALS and how to refer patients who are suspected of having this condition off to experts like Doreen and I. So Doreen, could you start us off with an overview of ALS and its epidemiology?
Of course. ALS is a relentless neurodegenerative disease that affects the motor neurons. The clinical hallmark of the disease is painless progressive weakness. Unfortunately, the average time from symptom onset to diagnosis of ALS is a little over a year, 12 to 14 months. And the average survival after symptom onset is only 2 to 5 years. There is quite a bit of variability in terms of how the disease presents. Death usually occurs due to respiratory failure. Although there is increasing understanding of the biology of the disease, to date, there is not yet a known cure. There are several FDA-approved medications, for example, riluzole and edaravone to slow disease progression, tofersen specifically for SOD1, genetic form of ALS, and dextromethorphan quinidine sulfate to address pseudobulbar affect, which is a symptom affecting certain individuals with ALS. It is a disease of middle age, with the onset being approximately in the 50s to 60s, but there is a wide range that is possible. Men are affected 1.5 to 2 times more often than women. The incidence is 2 to 3 per 100,000 per year, and it is more common in certain geographic places and certain occupations, for instance, in veterans. The prevalence is now 4 to 8 per 100,000, and there is a projected increase of 69% by 2040, likely due to the aging population and also increasing diagnostic sensitivity. The global disease burden in 2015 was 222,801 cases worldwide, but it's projected to be 376,674 in 2040. The lifetime risk for an individual to acquire ALS is 1 in 400. So with that context, Rick, could you please share some information on the pathophysiology of ALS and how ALS presents itself?
Yes, I can. As you mentioned, it's a neurodegenerative disease that most obviously affects a cell type called motor neurons. Motor neurons are kind of like wires that connect the front parts of our brains where we make decisions to the muscles that carry out our actions. And there's really 2 types of motor neurons, upper and lower motor neurons. In ALS, classically, both of these are involved. There are multiple different causes of ALS, and we divide them into 2 categories, genetic and sporadic. So genetic ALS means we can find a genetic mutation that is the cause of that person's disease. And currently that's true for about 12% of all the patients that we see with ALS. For the other 88%, which we call sporadic ALS, we can't find a single mutation that we think is causing their disease. Currently, we think there's probably a combination of susceptibility genes that open the door and then environmental exposures that allow the disease to come in. Once it starts at a cellular level, there's a lot of things going wrong. So we know there's something called transcriptional and translational dysregulation. We know that proteins in the cells are mislocalized and they tend to form clumps or aggregates. We know there can be inflammation in the brain and spinal cord. We know there can be oxidative stress, and we know there can be mitochondrial dysfunction. Now, at the level of the patient, typically what they're perceiving at the start is painless weakness. This most commonly starts in an extremity muscle, like a hand or a foot, but about 1/3 of the time, it starts in what we call bulbar muscles, the ones that control speech and swallowing. And very rarely, about 1% of the time, it can start in respiratory muscles. Once it starts, unfortunately, it usually progresses and it causes a loss of almost every muscle that we have control over. So patients will lose the ability to walk, to stand, to feed, to dress, to swallow, and eventually to breathe. Obviously, this whole thing can be quite devastating. I always remember the words of one of my patients who explained to me what it felt like. She said, ever since I was told I had this, it's kind of like I'm living in a box, and it gets a little smaller on all sides every day. And I know one day it's going to get so small and tight that it's going to crush me to death. I still get the goosebumps when I think of that. Progression tends to occur quickly. So most people with ALS have to make some difficult decisions about how much technology they'll allow to stay alive. Things like feeding tubes and attachment to ventilator in about 2 to 3 years from symptom onset. But it's really important to understand there can be a lot of variability. Stephen Hawking, one of the most famous humans to ever live with ALS, had the disease for 50 years. I've got a patient who's had it for 11 years and can still do marathons. And there's even a very small number of people, 63 as of today, that get it, progress for a while, and then appear to recover from it. I call them the ALS reversals. So Doreen, can you now tell us a little bit about why a timely diagnosis of this condition is so important?
Of course. So the reasons for the delay in diagnosis in ALS is very complex, and it's probably due to factors that are inherent to the disease itself. The fact that there aren't that many sort of diagnostic biomarkers, and also access to clinics. Sometimes the disease is not thought about early on in the diagnostic pathway. And again, that could be because the disease presents so variably in the population. It's also quite rare, and it can start extremely gradually. The motor symptoms of weakness can be quite subtle and gradual, and also very focal. Pain not tend to be a common symptom. And then again, getting back to the variability, it can occur in different locations, in the hand, or in the foot, or in the leg, or in the speech and swallow muscles, or in the breathing muscles. And there's also different degrees of upper and lower motor involvement, so it can look different in each of the regions for each patient. And no single test can make the diagnosis. So what happens is that a general neurologist, it may not be on the radar of primary care physician or general neurologist, or sometimes a general neurologist or primary care physician may suspect it, but they may choose to refer the patient rather than diagnose it and start treatment. And this might be because they don't have a lot of confidence in the diagnosis. And of course, it's a very difficult diagnosis to give to the person with extreme consequences. And secondly, they may not have enough time to spend in sort of the evaluation and delivery of the diagnosis. So it's very important to remember that there are two unusual presentations that should raise the suspicion that possibly a person has ALS. And this is sort of referred to, Rick had named this double trouble. But the first presentation that's unusual is if there's limb weakness that is painless and progressive. And also one thing to look out for would be fasciculations. The second unusual presentation is bulbar weakness, so impairment, slur in speech, and swallowing that is progressive getting worse over time, and that is unremarkable brain imaging. So both those sort of presentations should raise the possibility that this person may have ALS and may need to be referred for further testing or into a clinic. So if one encounters this as a provider, you can refer directly to an ALS clinic and an ALS expert. These clinics are really trying to increase and improve access. There are 200 clinics across the US with ALS expertise. These providers can be emailed directly, contacted directly by other means to try to get these patients in a timely fashion. So moving on to sort of how one would diagnose ALS and what the workup would include. The diagnosis of ALS is made clinically, so a careful history and examination is really key to the diagnosis. In terms of the history, the sort of attention to the detail in terms of, what the symptoms were, was there pain, was there sensory symptoms, did the symptoms occur, the presence or absence of symptoms like cramps or fasciculations, when the timing of the symptom onset, and a careful sort of history and review of past medical history and other risk factors is very critical. And in addition, a very careful physical examination. A patient is placed into a robe so that you can examine the muscles very thoroughly. And what we're looking for really is a combination generally of lower motor neuron and upper motor neuron findings. And again, these findings start typically within a region and then they spread to other regions later on. And when we think about lower motor neuron findings, sort of what we're looking for on our exam as an ALS physician, it would be weakness and muscle atrophy and fasciculations. For upper motor neuron findings, what we're typically looking for is increased reflexes, sort of pathologic spread of reflexes, things like clonus. And sometimes we're looking for, preserved in an extremity that has a lot of muscle atrophy or wasting. In addition, with the diagnosis, we are also looking for the absence of other explanations in terms of imaging, blood work, with the exception that sometimes there is a mild to modest rise in creatinine kinase in these patients. We're also looking for EMG to potentially confirm the lower motor neuron involvement for these patients. And then pathology, for instance, if a patient had, for some reason, undergone a muscle biopsy, one would expect that it would not be a muscle problem, but instead perhaps sort of more non-specific neurogenic changes. So the absence of an alternate explanation on pathology. And it does take a long time, sometimes from 1 year from symptom onset to diagnose. But again, hopefully with looking for some of these cues, an earlier diagnosis could be made. In terms of the diagnostic evaluation, really the gold standard remains the nerve conduction study in EMG. This is a two-part study where for the first part in the nerve conduction study, electricity is conducted across the nerve. And essentially in ALS, typically the nerve conduction study is underwhelming or normal. So usually there may be some reduction in the motor responses, but otherwise, as sensory responses are not involved, these would be normal. And you shouldn't see features of what's called demyelination or problems with the myelin of the nerve, for instance, in something like a conduction block. So we're looking for the absence of alternative diagnoses there. On the needle examination, and these are typically done, in multiple areas of the body when it's a question of ALS, what we see would be the combination of both active denervation, which you would see in a report like fibrillation potentials or positive sharp waves, and chronic reinnervation or motor unit remodeling in a number of muscles. And essentially, typically, especially if the symptoms are diffuse, you would see diffuse findings. In terms of neuroimaging, often the MRIs of the brain and spinal cord in people living with ALS may be quite normal, but it's important to know that sometimes there are potential abnormalities. These could be T2 hyperintensities that one can see in the corticospinal or motor tracts. These are often seen sort of early on in the internal capsule because this is where sort of the fibers are quite concentrated, and then sometimes in the entire tract from the motor strip to the spinal cord. And this is an increase in T2 signal and also volume loss. You can also see on spinal MRI what's called snake eyes, which is basically symmetric, so very symmetric, T1 hypointense and T2 hyperintense signals, which is basically in the anterior horns. These are not specific findings to ALS, and these would be taken in conjunction to the clinical examination that we just described, but important to know about. And then, as Rick had mentioned, there is a group of patients, about 12%, who will have an identifiable gene mutation. So part of the workup, and this could be sent potentially prior to being seen in the clinic, in the ALS clinic, is sponsored genetic testing for all known ALS genes. This is particularly important because, as mentioned, there is an FDA-approved medication for SOD1 ALS that could be initiated early. The gene panel will send all the known sort of genes associated or causing ALS, and this is an important part of the workup as well. So, Rick, with that, can you talk about why ruling out the differential diagnosis in ALS is important?
I can, but can I ask you a few follow-up questions first?
Sure.
So one question that I had is it possible that a person could come into a primary care doctor's office with early ALS and have a normal EMG and a normal MRI of their brain or spinal cord and normal genetic testing?
Absolutely. Absolutely. Especially early on, I mean, certainly in all situations, the MRIs can be entirely normal. Early on in ALS, the EMG may not have shown enough lower motor neuron dysfunction. There are also, and I think you'll be talking about this later, upper motor neuron forms, predominant forms of ALS where the EMG may be entirely normal. And the lab work may all be normal as well.
And then the other thing I wanted to just ask, because some of our primary care docs might run into this, is there are all these different sets of published diagnostic criteria out there. Like probably the one that's been used most over the history of ALS in my 25 years is called the El-Escorial diagnostic criteria. I know now we're using something called the Gold Coast criteria. But what do you want primary care docs to know about these types of criteria?
Thank you so much for asking. So the sort of probably most well known and most used in research potentially is the El-Escorial criteria. And what you'll see is there are essentially 4 categories, really based on the sort of level of certainty especially for clinical trial eligibility. In most cases, it's very likely that the patient does have ALS, but it's categorizing based on the certainty, diagnostic certainty, and also the number of regions that are involved with sort of upper and lower motor neuron characteristics. Pragmatically speaking, it's more sort of clinically relevant to use the Gold Coast criteria. This was a criteria that was used to sort of streamline this diagnostic criteria, and it was in 2019. And it's basically a pretty simple criteria that basically states that one has to have, to meet this criteria, sort of worsening motor impairment by history and exam that we've talked about, and preceded by normal motor function. And then there has to be the presence of combined upper and lower motor neuron findings in at least one body region. And then there has to be due diligence to exclude other diagnoses with investigations. And that's probably the sort of easiest diagnostic criteria to be used clinically.
I so appreciate that. So you asked me a little bit about the differential diagnosis and why it's really important to think about mimickers. And I would say it comes back to this fact that we still, even after 100 years from when it was first described, we don't have a test that comes back positive or negative for ALS. And so there's two types of mistakes that can be made. The most common mistake that I see in my patients is they've been told along the way that they have some other type of medical problem and they receive treatments for those other problems. And, sometimes those treatments are benign. Sometimes they're pretty serious. Like about 15% of the 5,000 patients that I've seen in my career with ALS have had an unnecessary surgery. Most often it's a neck surgery or back surgery or a carpal tunnel release. And, obviously we don't want to put people through unnecessary surgeries, but this also contributes to diagnostic delay. Like, if a surgeon is involved and operates on something that isn't a surgical problem, that can add another 2 or 3 months to the patient's journey before they get in to see one of us and get started on disease modifying therapies. Of course, the one everybody worries about is a false positive, where you tell someone they have ALS and what they actually have is something else, especially when that something else might be reversible. And I would say the most important mimickers to exclude are mass lesions. Like you can have a mass lesion in the brainstem, for example, a brainstem glioma that's compressing some of the cranial nerves and leading to progressive problems with speech and swallowing that might be misdiagnosed as bulbar onset ALS. Or you could have a mass lesion in the spine, a tumor, or more commonly, a combination of disc bulges and arthritis that lead to something called spinal stenosis. And this can cause a combination of upper and lower motor neuron signs in the limb muscles. And, these are easily reversed if we can detect them early. And it's nice to know that these are almost always detectable with simple imaging, like MRI scans of the brain or MRI scans of the spine. Now, there are some more rare mimickers that I think are also really important to exclude because they're reversible. And when I say rare, I would say I think these occur far less than 1% of the time. And for me, I divide them into categories. So I've got an autoimmune category, I've got an infectious category, and I've got a metabolic category. And so in that autoimmune ALS mimicker category, I've got two things. One is called multifocal motor neuropathy. This is an antibody-mediated disease where the immune system is actually attacking the coverings of motor neurons. And so one way to distinguish this from ALS is that people with multifocal motor neuropathy almost never have upper motor neuron signs. So they almost never have the spastic tone or the hyperreflexia or the Babinski signs. Now, the one exception to that I've seen is a patient who was on a TNF alpha modulator who actually did have a combination of upper and lower motor neuron signs with their multifocal motor neuropathy. People with multifocal motor neuropathy should always have either conduction blocks on their nerve conduction studies, or they should have detectable antibodies in their blood to something called gangliosides. So a common one that we check for is ganglioside M1, GM1 antibodies. But this disease is important to look for because it's very responsive to immunomodulatory therapies like IVIG. Another one in this category is celiac disease. Strange. I mean, most people with celiac disease have a GI presentation, but it has been described that people can have neurological presentations. And there's even a handful of cases of people with what looks like ALS as the presentation for their celiac disease. Again, really important to look for because it's very responsive to a gluten-free diet. So what I do is check TTG antibodies, and if they're positive, I do an intestinal biopsy. Within the infectious category, HIV, HTLV, syphilis, and West Nile virus have all been reported to cause a progressive motor neuron disease that can look somewhat like ALS. And so in my history, I ask people if there's any HIV risk factors And if there are, I check for HIV, HTLV, and syphilis. When it comes to West Nile virus, I think that one's especially uncommon. And I think it's pretty obvious because first, the motor neuron disease is usually rapidly progressive over days, not over months. And second, they have systemic infection or signs of systemic infection like fever. And then there can be a couple of metabolic conditions, hyperparathyroidism and copper deficiency. So in all my patients, I check their calcium, their PTH, and their copper levels. And so, Doreen, can you quickly tell us here at the end why early referral to a multidisciplinary care clinic is so important?
Absolutely. Thank you. So the diagnostic delay can be extremely burdensome to patients because it limits the ability to intervene early and also may limit access to treatments and trials because the disease has already progressed so much. And so it's very critical to get these patients early into the multidisciplinary clinic. So just to sort of take a step back and describe the multidisciplinary clinic. So it truly is a team effort. ALS affects so many functions so quickly and affects the patient and family in such a holistic and multifaceted way that it would be very difficult for one provider to address all of the evolving needs. And we really do want to, in the multidisciplinary clinic, help with anticipatory guidance, meaning that we want to try to be proactive about issues rather than reactive to them. So therefore, the multidisciplinary team has a true team of individuals, over 20 clinicians, who are dedicated to responding in a very timely fashion to the evolving needs of these patients. So things like medications, equipment, exercise, nutrition, education, these can all be delivered. And the disease does change quite a bit throughout the disease journey. And so the team is well poised to meet those evolving needs. It has been shown that being part of a multidisciplinary clinic for a patient is associated with better quality of life scores, potentially a reduction in hospitalization, and also a longer survival for these patients. So, Rick, what are things that a primary care physician could do when a patient is waiting to see one of these ALS multidisciplinary clinics?
Well, thank you. I think there's two really important things. First, be sure to give people some hope. There's a lot of variability in how this progresses, and there's a lot of things we can do now to improve quality and length of life. And second, go ahead and start treating bothersome symptoms. There's no reason to wait for a definitive diagnosis to treat things like anxiety, depression, insomnia, cramps, constipation, urinary urgency, pseudobulbar affect. These are all things that rob people of quality of life that are very reversible. Well, Doreen, I've really enjoyed talking to you today, and I'll just summarize the key points that I think we've made. First, that ALS is a degenerative disease most obviously affecting motor neurons, which has devastating effects on individual patients and on societies. And I think early diagnosis is important. What are your key takeaways?
I would agree. I would add that there are currently several therapies that can improve quality of life and slow disease progression. And due to the improved understanding of ALS, there have been many promising clinical trials, and there are better treatments coming. Collaborations with colleagues, people living with ALS, are key to improving our clinical care research and advocacy. And we are really about getting better together. And I think I would remember, as you put it, the sort of double trouble, the painless progressive weakness in the limb, or the scenario of bulbar weakness, such as speech and swallowing, that is progressive with an unremarkable brain MRI, and promptly refer to an ALS specialist under those circumstances.
Fantastic. Doreen, I've really enjoyed talking to you. And thanks to all of you, the audience, for spending this 30-minute period with us. Take care.